Welcome back for part 2 of chapter 12. Nursing care of patients having surgery. We're starting on page 180, preparation for surgery. Pre-operative preparation checklist. A pre-operative checklist may be completed if the nurse signs it before the patient is the nurse signs it before the patient is transported to surgery. The checklist provides the following guidelines for preoperative preparation of the patient. An identification band is placed on the patient. A hospital gown is given to the patient to wear. Underwear is removed depending on the type of surgery. Vital signs are taken and recorded as baseline information of the patient's status. Makeup, nail polish, and artificial nails, if applicable, are removed to allow assessment of natural color and pulse oximetry for oxygenation status during and after surgery. Removal of hairpins, wigs, and jewelry prevents loss or injury. Rings, such as wedding rings, are taped in place if the patient does not want to take them off, except if the ring is on the operative side, chest or arm surgery, because edema may occur. Dentures, contact lenses, and prosthesis are removed to prevent injury. Some patients are concerned about body image and do not want family members to see them without dentures or makeup. Remove dentures after the family goes to the waiting room and insert them before the family sees the patient post-operatively. All orders, diagnostic test results, consents, and history and physical required in medical record are reviewed for completion and documented on the checklist. Patient valuables are recorded and given to a family member or locked up per institutional policy by the nurse. Anti-embolism devices are applied if ordered. Patients are asked to void before sedating preoperative medications are given unless a urinary catheter is present to prevent injury to the bladder during surgery. So this is the pre-op surgical checklist. The ID band is on that the patient was NPO as ordered. Pre-op teaching was completed. The informed consent is signed. History and physical are on the chart. Allergies are noted. Lab results are recorded for CBC, potassium, depends on what's ordered, what's needed. ECG on chart, chest x-ray report on chart, showered / bathed, because we want them clean, hospital gown on, preps completed as ordered, anti-embolism stockings, jewelry taped or removed, valuables, dentures, prosthesis removed, hairpins, wigs, makeup, nail polish. One acrylic nail can be removed. You don't have to do all of them. Contact lenses removed. The patient has voided. We've taken their vital signs for temperature, pulse, respiratory, and blood pressure. Pre-op medications were given. The side rails are up. An IV was started, eyeglasses, and hearing aids to OR. Old chart to the OR, x-rays to the OR, the location of the family next of kin is recorded, and the client is ready for surgery along with the time, and the nurse signs the form. Okay, so let's keep going. Pre-operative medications. Pre-operative medications are given at the time ordered or on call to surgery. For example, surgery calls to instruct that it is time to give the drugs. If sedatives or analgesics are given, bed rails are raised for safety per policy, Instruct the patient not to get up alone. Preoperative medications. Analgesic or antipyretic relieves mild to moderate pain and reduces fever. Examples would be acetaminophen or ofurmev. Nursing implications, given intravenously as a 15-minute infusion. Antipyretic effect may mask fever. Anti-anxiety and sedative hypnotics for sedation and anxiety reduction. Examples are diazepam or Valium, lorazepam or Ativan, and midazolam, or Versed. Nursing implications, contraindicated for acute narrow angle glaucoma. Monitor respirations. Antiemetics control nausea and vomiting. Examples include metoclopramide or Reglan, ondansetron or Zofran, prochlorperazine or Compazine, promethazine hydrochloride or Phenergan. Nursing implications, redness, pain, or burning at the site of injection, increased drowsiness with opioids. Antibiotics, prevention of post-operative infection. Examples, variety of antibiotics used. Nursing implications, give within 30 to 60 minutes of incision as prescribed for best effect. Opioids, bind to opioid receptors in the central nervous system to alter perception of pain and enhance post-operative pain relief. Examples of fentanyl or Sublimase, also hydromorphone hydrochloride, also called Dilaudid. There is meperidine, also called Demerol, and morphine sulfate. Nursing implications, monitor vital signs, level of sedation, and respiratory status. Avoid meperidine use in older adult. Transfer to surgery department. When the surgery department is ready, the patient is transported to the surgical holding area. The patient's inhaler medications for those with asthma and glasses or hearing aids to aid communication are taken with the patient. Family members can go with the patient. During surgery, the family waits in the surgical waiting area, which is a communication center. The family can be called by cell phone or given a beeper. They are kept informed of the patient's status. Post-transfer to surgery department. After the patient goes to the surgery department, prepare the patient's room and necessary equipment to be ready when the patient returns from the peri-anesthesia care unit, the PACU. Patient arrival in the surgery department. The holding area nurse greets the patient. The nurse then verifies the patient's name, age, allergies, surgeon performing the surgery, informed consent, surgical procedure, including the correct site, especially right or left when applicable, and medical history. Next, the nurse answers questions and alleviates anxiety. The operative side is marked, usually by the person most informed about the patient and procedure, the surgeon, and confirmed by the patient. This helps ensure that the right surgery for the right patient on the correct section of the body is done. The patient is introduced to the anesthesiologist and the certified registered nurse anesthetist. They also verify patient information and explain the type of anesthesia to be used. IV fluids are started. Prophylactic antibiotics may be timed to be given 1 hour before incision time. This timing has been shown to reduce surgical site infections. Before entering the operating room or OR, the patient should be told what to expect. If the room feels cool, you can request extra blankets. There's a lot of equipment in the room, including a table and large, bright overhead lights. Several healthcare team members will introduce themselves to you, and your surgeon will greet you. A safety checklist will be performed. Table 12.8, post-operative patient hospital room preparation. Bed with wheels locked. Ensure bed linens are clean and changed if used by the patient before surgery. This reduces contamination of the surgical wound. Place disposable, absorbent, waterproof pads on the bottom sheet if drainage is expected. This protects the linen from wetness and soiling, so a patient in pain does not have to be disturbed for a linen change. Apply lift sheet on the bed of a patient needing assistance with repositioning. This makes lifting and turning easier for the patient and nurse. Have warm blankets available. The patient may be cold. Fan fold top cover to end of bed or to side of bed away from patient transfer side. This readies the bed to receive the patient on transfer and allows covers to be easily pulled up over the patient. Obtain extra pillows as needed for positioning, elevating extremities, and splinting during coughing. Pillows help maintain position when the patient is turned, splint an incision during coughing, or elevate operative extremities for comfort and swelling reduction. Equipment. Have vital equipment available. Promotes the ability to obtain vital signs. Have vital sign equipment available. Have IV pole controller pump available. Surgical patients have IV infusions post-operatively. Have oxygen set up as needed. After tracheostomy, patients wear humidified oxygen masks. Prepare suction setup for tracheostomy, nasogastric tube, or drains as ordered. Suction may be ordered related to surgical procedures. Sterile suction, tracheostomy, nasogastric tube, thoracic, abdominal, and gastrointestinal surgery, a T-tube for a cholecystectomy. Have emesis basin at bedside. Nausea or vomiting may occur, especially after movement during transfer. Have tissues and washcloths in the room. This promotes comfort, e.g., washing face or a cool cloth on the forehead. Have urinal or bedpan available in the room. Patients may be unable to get out of bed for first voiding. Obtain special equipment as indicated by the surgical procedure. Institutional policy and surgeon orders may require specialized equipment. Jaw surgery requires suction, wire cutters, tracheostomy tray, and a tracheostomy requires suction, extra tracheostomy set, and tracheostomy care supplies. Preoperative warming. Pre-warming the patient's skin before anesthesia is helpful. This can help maintain normal body temperature, normothermia. It can also reduce intraoperative hypothermia. Associated complications can be prevented. A forced air warming device used for 30 minutes may reduce hypothermia. Patients should be normothermic, body temperature within normal range before transfer to surgery. Intraoperative phase. This is on page 183 of the 6th edition. The next phase of the perioperative period is the intraoperative phase. It begins when the patient is transferred to the operating table. Surgery can be done in a hospital or outpatient surgical center. Additionally, surgery is performed in HCP offices, cardiac catheterization laboratories, radiology centers, emergency rooms, and specialized units that perform endoscopy procedures. Be safe. Prevent mistakes in surgery. Make sure that the correct surgery is done on the correct patient at the correct location on the patient's body. Mark the correct place on the patient's body where the surgery is to be done. Pause before the surgery to make sure that a mistake is not being made. The OR is designed to enhance aseptic elimination of microorganisms technique. Clean and contaminated areas are separated. Special ventilation systems control dust. They prevent air from flowing into the OR from hallways. The temperature and humidity in the OR is controlled to discourage bacterial growth. The OR temperature is recommended to be 68 Fahrenheit to 77 Fahrenheit or 20 to 25 degrees Celsius. This reduces patient hypothermia. Everyone entering the OR wears surgical scrubs, shoe covers, caps, masks, and goggles. This protects the patient from infection. It also protects the staff from blood-borne pathogens. Traffic in and out of the OR is limited. Strong disinfectants are used to clean the OR after each surgical case. Prior to surgery, surgical team members must perform a sterile surgical hand scrub. This reduces the number of microorganisms on their hands and arms. Jewelry, for example, watches, rings, and bracelets, is removed. Fingernails are kept short and clean. Artificial nails and nail polish are not recommended. They may harbor microorganisms. If nail polish is worn, it should not be chipped. It should be removed and reapplied every 4 days. Sterile gloves are worn by the surgical team to keep the surgical field sterile. A surgical case cart contains surgical instruments specifically for the patient's case. The LPN may assist with maintaining the sterile surgical field. A nursing plan of care focused on safety is prepared before the patient arrives in surgery. It is developed with the patient's pre-admission assessment data. The LPN may help position the patient onto the operating table. A safety strap is carefully applied. A timeout is taken to verify all patient and surgical information to prevent mistakes. Then monitoring equipment is applied. Readings are recorded. The anesthesia provider begins anesthesia and says when to position the patient. Positioning is done carefully to prevent pressure points. This can cause tissue or nerve damage. Tubes that are needed, such as nasogastric and G-tube or urinary catheter, are inserted by the RN. Surgical health care team members and roles. Members of the surgical healthcare team and their roles are as follows. Risk for injury related to perioperative positioning, chemicals, electrical equipment, and effective being anesthetized is free from injury. Risk for impaired skin integrity related to chemicals, positioning, and immobility. maintains skin integrity. Patient allergies, for example, to skin prep solutions, are rechecked. If the patient requires body hair removal, hair is removed with electric clippers. Shaving is avoided. It can cause microabrasions that become colonized by microorganisms. Then the skin is cleaned with a skin prep solution such as povidone iodine. A large area around the operative site is scrubbed. This allows the incision to be extended as needed. The scrub is completed in a circular motion from inner to outer edge. An allergic reaction to the solution can cause skin redness and blistering wherever the solution was used. After the skin is scrubbed, a sterile drape is applied. The incisional area is left exposed. Evidence-based practice. Clinical question. Does hair removal affect postoperative surgical site infection? Evidence. A review of 14 studies, 11 were randomized controlled trials, compared various hair removal methods, including shaving, clipping, and depilatory creams, amongst each other, and with the option of not removing hair preoperatively. There were no significant decreases between not removing hair and methods of hair removal. Implications for nursing practice. Unless it is necessary, it is recommended to avoid operative site hair removal from surgical sites. There is no advantage to shaving the operative site. In addition, patients expressed increased satisfaction when hair removal was avoided. When hair removal is necessary, it is recommended to clip hair rather than shave to avoid skin irritation and micro irritation. Be safe. Use medicines safely. Before a procedure, label medicines that are not labeled. For example, medications in syringes, cups, and basins. Do this in the area where medicines and supplies are set up. Anesthesia. Anesthesia is used during surgery mainly to prevent pain. The type of anesthesia and the anesthetic agents are ordered by the anesthesia provider with input from the patient and surgeon. There are two types of anesthesia, general and local or regional. General anesthesia causes the patient to lose sedation, consciousness, and reflexes, or lose, sensation, consciousness, and reflexes. It acts directly on the central nervous system. Local anesthesia blocks nerve impulses along the nerve where it is injected. This results in the loss of sensation to a region of the body. There is no loss of consciousness. General anesthesia. General anesthesia is given by IV or inhalation. It is used if the surgical procedure will take a long time and there is a need for muscle relaxation. It is also used when patients are anxious or do not want local anesthesia. In addition, it can be used for patients who are unable to cooperate, as with head injury, muscle disorders, or impaired cognitive function. Intravenous agents. To begin most general anesthesia, the patient is induced, meaning to cause anesthesia. A short-acting IV agent is used to provide rapid, smooth induction. The period from when the anesthetic is first given until full anesthesia is reached. These agents last only a few minutes and are used along with inhalation agents. After induction, the patient is intubated with an ET tube. This is used to provide anesthesia and mechanical ventilation. Inhalation agents. Inhalation agents maintain anesthesia during the surgery. These agents are delivered, controlled, and excreted via mechanical ventilation. Complications. Side effects of general anesthesia are usually brief. They include nausea and vomiting, confusion, longer duration in older adult, sore throat, and shivering, likely from the body cooling. Serious complications occur rarely and include respiratory distress, malignant hyperthermia, and more commonly in older adults, delirium temporary, and cognitive dysfunction. For example, long-term memory loss, difficulty learning, thinking, and concentrating. Inhalation agents and the ET tube can be irritating to the respiratory tract. Complications that can occur include laryngospasm, sudden violent contraction of the vocal cords, laryngeal edema, or injury to the vocal cords. When the tube is removed, closely monitor the patient. Be prepared to provide respiratory support. Assist with reintubation if needed. Adjunct agents. An adjunct agent is a medication used with the primary anesthetic agents. These medications include opioids to control pain, muscle relaxers to avoid movement of muscles during surgery, antiemetics to control nausea or vomiting, and sedatives to supplement anesthesia. Side effects related to a specific medication, such as itching with narcotics, can occur. Local or regional anesthesia. Local or regional anesthesia is selected for the patient who wants to be awake, is not anxious, can tolerate the local agent, and is not required by the surgical procedure to be unconscious or have relaxed muscles. A local agent can be placed directly on the surgical area or injected into the tissue where the incision is to be made to numb a small area. A regional block is done by injecting the local agent along a nerve that carries impulses into the region where anesthesia is desired. There are several types of regional blocks. A nerve block is the injection of a local agent into a nerve at a specific point. A beer block is done by placing a tourniquet or cuff on an extremity to remove the blood. The local agent is then injected into the extremity. A field block is a series of injections surrounding the surgical area. Local or regional anesthesia. Spinal and epidural blocks. Injection of a local agent into the subarachnoid space produces spinal block. Epidural block occurs when the local agent is injected into the epidural space. Spinal and epidural blocks are used mainly for lower extremity and lower abdominal surgery. Both motor and sensory function are blocked. The patient must be carefully monitored for complications. Hypotension results from sympathetic blockade. The blockage causes vasodilation and reduces venous return to the heart. Cardiac output is reduced. Respiratory depression results if the block travels too far upward. As the block wears off, patients feel as if their legs are heavy and numb. This is normal. Reassurance should be offered to the patient that this type of feeling does not last long after the block wears off. Complications: back pain, urinary retention, hematoma, nerve damage, or post-dural puncture headache can occur with regional anesthesia. Headache may occur from leakage of cerebrospinal fluid, CSF, out of the needle puncture hole in the dura. Pressure is then reduced on the spinal cord and brain. This causes a low pressure headache, which can be severe. The headache can worsen with standing or sitting. The use of less than 25 gauge spinal needles helps prevent headache. Nausea, dizziness, tinnitus, and vision disturbances may be present. The headache usually will resolve in 7 to 10 days. If symptomatic and conservative treatment is not effective, an autologous epidural blood patch can be used. This sterile procedure is done by the anesthesiologist. To create an epidural blood patch, approximately 15 milliliters to 20 milliliters of the patient's blood is injected into the epidural space, one interspace below the previous puncture site. Procedural sedation and analgesia. Procedural sedation and analgesia, formerly conscious sedation, is purposeful minimal sedation. It does not cause the complete loss of consciousness. The patient may fall asleep, but then arouse easily and respond. Patients remain in control of their own airway. They are comfortable and respond purposefully. Medications such as propofol or diprivan, ketamine or Ketalar, midazolam or Versed, and opioids, fentanyl or morphine, are given to produce sedation. Selection of patients who are eligible for this sedation is based on the procedure, the patient's general health, and patient or physician preference. Examples of short procedures for which this type of sedation is used are dental procedures, endoscopy, cardioversion, and closed fracture reduction. Procedural sedation can be administered by anesthesia providers or ordered by a physician and given by a specially trained RN. The patient does not eat for 6 hours before the procedure. Clear liquids are allowed up to 2 hours before the procedure. A signed informed consent is obtained. Then an IV is started. Every 5 minutes, vital signs, electrocardiogram or ECG, and oxygen saturation are checked. Changes are reported to the HCP. Oxygen may be given by nasal cannula or mask. Emergency equipment, for example, airway suction, defibrillator, drugs, is on standby. After the procedure, the patient awakens quickly and remembers nothing or little about the procedure. The patient is monitored about every 15 minutes for response to the procedure and medications. Rare side effects include drowsiness, headache, and nausea. The patient is ready for discharge when vital signs return to baseline and are stable. Oral fluids are retained and voiding has occurred if applicable. Written and oral discharge teaching must be given to both the patient and the responsible adult to whom the patient is being discharged. The responsible adult and the patient must sign the instructions. These state that an adult must drive the patient home and provide a safe environment. They also state that the patient must not and will not drive or operate heavy machinery or sign legal documents for 24 hours. Learning tip. In comparison with general anesthesia, procedural sedation and analgesia is less invasive, requires less medication, causes less depression of the cardiovascular and respiratory system, and allows the patients to return more quickly to a wakeful state. Transfer from surgery. When surgery is completed and anesthesia stopped, the patient is stabilized for transfer. The patient is normothermic upon transfer from surgery. After local anesthesia, the patient may return directly to a nursing unit. After general and spinal anesthesia, The patient goes to the PACU or an intensive care unit. Patient safety is an important concern, and the patient is never left alone. Ensuring a patent airway and preventing falls and injury from uncontrolled movements are priorities. The anesthesia provider and OR nurses transfer the patient to the PACU. They monitor the patient until the peri-anesthesia nurse can receive the handoff report and assumes care of the patient. This promotes safe recovery from anesthesia. The family is updated on the patient's status by the surgeon. Post-operative phase. The post-operative phase is the final perioperative phase. It begins when the patient is admitted to the PACU or directly to a nursing unit. It ends with the patient's post-operative evaluation in the surgeon's office. Admission to the peri-anesthesia care unit. Responsibilities of the peri-anesthesia nurses are listed in box 12.4. It is essential for nurses to perform hand hygiene between patients in the PACU. When patients admitted to the PACU, when an admission assessment is done, oxygen by nasal cannula, mask, ET tube, or mechanical ventilation is given after general anesthesia. IV fluid infusion is maintained. Continuous monitoring is done at least every 5 to 15 minutes. This includes ECG, vital signs, exhaled end-tidal carbon dioxide, which is EtCO2, and pulse oximetry. If the patient's temperature is normal, the temperature is monitored hourly and at discharge from the PACU. Passive methods to maintain temperature are continued. Room temperature is kept at or above 75 degrees Fahrenheit or 24 degrees Celsius. A head covering and warm blankets are used. If shivering due to hypothermia occurs, the temperature is retaken. For hypothermia, active warming, usually with a forced air warming system, is used. Body temperature is monitored every 15 minutes until normal. The patient must be normothermic before the PACU discharge. Peri-anesthesia nursing responsibilities. Airway maintenance. Vital signs including temperature, oxygen saturation, and exhaled end-tidal carbon dioxide, EtCO2. Body systems assessment from surgical site, patient safety, monitoring anesthetic effects, pain management, accurate intake and output, identifying peri-anesthesia care unit discharge readiness, documentation, handoff report to receiving nurse includes name, allergies, procedure, type of anesthesia, status, complications, oxygen, dressing slash drain slash equipment, medications, post-operative orders, pertinent history, family, opportunity to ask questions. The surgical site incision or dressing is monitored. Drainage amount and color, as well as hematoma formation, are documented and reported to the HCP as needed. Tubes, for example, chest drains, NG, urinary catheter, and other equipment are checked for proper function. IV analgesics or PCA are given for pain as needed. Antiemetics are administered for nausea or vomiting. Coughing and deep breathing are encouraged unless they are contraindicated by the surgical procedure. For example, hernia repair, eye, ear, intracranial, and jaw surgery and plastic surgery. If the patient is no longer NPO, ice chips or sips of water are offered for a dry mouth when the patient is fully awake. Nursing process for post-operative patients in the peri-anesthesia care unit. Postoperative complications may occur due to the surgical procedure, anesthesia, blood and fluid loss, immobility, unrelieved pain, and or other diseases the patient may have. Nursing care focuses on preventing, detecting, and caring for these complications. Respiratory function, data collection. Normal respiratory function can be altered in the immediate post-operative period by airway obstruction, hypoventilation, secretions, laryngospasm, or decreased swallowing and cough reflexes. Respiratory function assessment includes respiratory rate, depth, ease, and pattern. Breath sounds, chest symmetry, accessory muscle use, and sputum are also observed. Nursing diagnosis, planning, and implementation. Ineffective airway clearance related to obstruction, anesthesia medications, and secretions. Expected outcome. The patient will have a patent airway at all times. Ensure that the patient maintains a patent airway because airway obstruction may result when relaxed muscles allow the tongue to block the pharynx in patients with a decreased level of consciousness. Use jaw thrust method to manually open the patient's airway if the patient has snoring respirations and is not completely emerged from the anesthesia. Ineffective breathing pattern related to anesthesia, pain, and analgesic/sedative medications. Expected outcome. The patient will maintain a normal entitled carbon dioxide and oxygen saturation SA2 levels at all times. Maintain oxygen therapy as ordered to prevent hypoventilation, which can be an effect of anesthesia medications, analgesics, or decreased level of consciousness. Encourage deep breathing to expand the lungs and expel anesthetic agents. Maintain continuous positive airway pressure, CPAP/bilevel positive airway pressure, BiPAP, to treat sleep apnea. Patients may bring their own CPAP/BiPAP machines with them. Report respiratory depression or abnormal EtCO2 to the anesthesiologist to obtain prompt treatment. Risk for aspiration related to depressed cough and gag reflexes and reduced level of consciousness. Expected outcome. The patient will have clear lung sounds with no signs of acute aspiration, coughing, wheezing, fever, respiratory distress, cyanosis, chest pain at all times. Position the patient onto side unless contraindicated to protect the airway until fully awake. Use suction equipment as needed to clear secretions or emesis. Evaluation. The goal for ineffective airway clearance and aspiration is achieved if the patient's airway remains patent and lung sounds remain clear. The goal for ineffective breathing pattern is met if the patient's respiratory rate is within normal limits, no dyspnea is reported, and arterial blood gases are within normal limits. Cardiovascular function. Data collection. Alterations in cardiovascular function can include hypotension, arrhythmias, and hypertension. Hypotension can be the result of blood and fluid volume loss, cardiac abnormalities, or a side effect of the anesthesia or pain medication. Shock can also result from significant blood and fluid volume loss or from sepsis. See Chapter 9. Arrhythmias can occur from hypoxia, altered potassium or magnesium levels, hypothermia, pain, stress, or cardiac disease. New onset hypertension can develop from pain, a full bladder, or respiratory distress. Cardiovascular function assessment includes heart rate, blood pressure, ECG, and skin temperature, color, and moistness. Vital signs are compared with baseline readings to determine patient status. Tachycardia, hypotension, pale skin color, cool, clammy skin, and decreased urine output indicate hypovolemic shock. This requires reporting and prompt treatment. Nursing diagnosis, planning, and implementation. Deficient fluid volume related to blood and fluid loss or NPO status. Expected outcome: the patient will maintain blood pressure, pulse, and urine output within normal limits at all times. Check dressings, incisions, and drains for color and amount of drainage to detect fluid loss. Maintain IV fluids at ordered rate to replace lost fluids but avoid fluid overload. Monitor intake and output to detect imbalances. Evaluation. The goal for deficient fluid volume is met if vital signs and urine output are within normal limits. Nursing care tip. Tachycardia is a compensatory mechanism designed to provide adequate delivery of oxygen in times of altered function. It is usually the earliest warning sign that an abnormality is occurring. It should be an indicator to assess the patient. Ask yourself what this particular patient is likely to be experiencing that is compromising oxygenation. This will allow you to begin prompt intervention. Patient condition and possible causes of compromised oxygenation. Postoperative could be hemorrhage, respiratory depression or pain. Myocardial infarction could be caused by cardiogenic shock, pain, or arrhythmia. Respiratory could be respiratory distress. If there's trauma, there could be a hemorrhage or severe pain. Neurologic function. Until its effects wear off, anesthesia can alter neurologic function. Patients may arrive in the PACU awake, arousable, or sleeping. Patients who are sleeping should become more alert during their stay in the PACU. As they emerge from anesthesia, they may become agitated or act wild for a short time. This is called emergence delirium. During this time, it is important to provide safety measures to prevent injuries such as side rails and restraints, following restraint protocols to protect IV lines and keep ET tubes in place. Once resolved, patients return to a calm state and have no recollection of the episode. Movement, sensations, and perceptions may also be altered by anesthesia. Movement is the first function to return after spinal anesthesia. Confused patients may be agitated or frightened when they awaken. Review older adult patients' cognitive history. It is helpful to know how caregivers communicate with patients. If possible, have a familiar relative or caregiver with the patient in the PACU. They can calm the patient and help with communication. Watch for nonverbal pain cues. See the next section. Understand that postoperative patients have pain and require pain relief interventions, even if they cannot report it. Data collection. A neurologic assessment includes level of consciousness, orientation to person, place, time, and event, pupil size and reaction to light, and motor and sensory function. Abnormalities are reported to the anesthesia provider. Pain, data collection. If the patient is awake, ask the patient to rate the presence of pain using a pain scale. Document the location and character of the pain. If the patient is not fully awake, monitor vital signs and nonverbal indications of pain. Nonverbal indications of pain can include abnormal vital signs, restlessness, moaning, grimacing, rubbing, or pulling at specific areas or equipment. Acute pain related to tissue damage, mechanical incision. Expected outcome. The patient will report that pain is relieved at a satisfactory level within 15 to 30 minutes of the pain report. Monitor the patient for pain because pain may result from the surgical procedure, movement, deep breathing, anxiety, a full bladder, positioning during surgery, NG tubes, catheters, IVs, ET tubes, or prior medical conditions such as arthritis, cancer, or back pain. Give ordered IV opioid analgesics promptly for their rapid onset. Begin PCA as ordered, as it is often initiated in the PACU. Reposition the patient, provide warmth, and assist to empty full bladder to alleviate pain. Play music, for example, nature sounds or classical music in the PACU. Dim lights and reduce room noise to help alleviate pain. Evaluation. The goal for pain is met if the patient reports a satisfactory decrease in level of pain. For example, the patient reports pain of 10 on a scale of 0 to 10. 30 minutes after you medicate the patient rates the pain as 2 on a scale of 0 to 10. The patient indicates that 2 is an acceptable pain level, so the goal is achieved. Family visitation. Family visitation in the PACU has been shown to be helpful to patients and their families. Allowing family visitation varies by hospital. Patients and families should be educated about the expectations for family visitation. During visitation, confidentiality of all patients in the PACU must be ensured per Health Insurance Portability and Accountability Act of 1996, HIPAA. For example, some patients may not want their surgical procedure revealed to their spouse or any family members. Discharge from the peri-anesthesia care unit. The length of stay in the PACU for a stable patient is about 1 hour. A post-anesthesia recovery scale is used to score the patient's readiness to be discharged. The scale rates categories such as respiration, oxygen saturation, level of consciousness, activity, and circulation. The anesthesiologist discharges the patient for transfer to a nursing unit or home when discharge criteria are met. The pain may be transferred to the ICU. This is done if the patient is unstable and/or frequent or invasive monitoring is needed. Transfer to the nursing unit. Transfer to the nursing unit. The peri-anesthesia nurse provides a handoff report to the unit nurse when the patient is transferred to the nursing unit. The patient is moved into a bed on the nursing unit unless the patient is being transferred in a bed as may be done with major orthopedic procedures. Assistance is given to prevent dislodging of IVs, tubes, and drains. The following safety interventions are performed per agency policy to help prevent falls. The bed is placed in its lowest position with the wheels locked, the side rails raised, and the call button within the patient's reach. Instructions are given for the patient to call for assistance with ambulation. Assistance by one or two healthcare workers is given to help the patient get out of bed. The patient should be encouraged to sit on the side of the bed prior to standing. When the patient gets up postoperatively, especially for the first time, he or she may be weak or dizzy. Discharge criteria for peri-anesthesia care unit or ambulatory surgery. Vital signs stable with temperature normal, patient awake or at baseline level of consciousness, drainage or bleeding not excessive, respiratory function not depressed, oxygen saturation above 90%. Additional criteria for ambulatory surgery: no nausea or vomiting, no intravenous opioids within the last 30 minutes, voided if required by surgical procedure or ordered, is ambulatory or has baseline mobility, understands discharge instructions, provides means of contact for follow-up telephone assessment, and is released to a responsible adult. So now we are on the nursing process for post-operative patients. And this is on page 190. So we are going to end part 2 here, and we will start part 3 on page 190 at the nursing process for post-operative patients.